Southwest Airlines. As always, Angel Flight West has made a difference. I'd like to share a couple of quotes with you to tell you what the impact has been. From a physician on the reservation, he said, "The rate of infection amongst our medical personnel is low here due to Angel Flight West pilots and with love from strangers. Without this PPE, we would be looking at a different situation. You literally saved lives." And from a nurse at a rural hospital in Colorado, she said, "I knew what we were getting would be helpful, but when I saw that plane coming in with those masks, I still cried for joy." And to close, from the director of an emergency room on the Navajo reservation, he said, "I wanted you to know how palpable the confidence was when nursing received your gowns. No one who is 100% clinical here has worried about PPE except for myself. Yet they still recognized how powerful this would be. 3 days after your gowns arrived, our disposable supply was down to 1/2 of a day. So thank you again and again, thank you." And now I say thank you to all of you who have contributed to this process, whether it be flying missions, donating funds, or supporting our staff. And now I'm proud to introduce our Executive Director, Josh Olson.
Thanks, Sherry. And I want to personally thank you, Sherry, and your team and the whole staff for Angel Flight West. As Sherry mentioned, it's been unprecedented and difficult, and been inspired working alongside of them and being able to pivot to be part of the solution to coronavirus pandemic and serving through this crisis, which we're fortunate to do. So thank you, Sherry, and thank you to all of our volunteers. You know, the strength of Angel Flight has been and always will be our volunteers stepping up in times of need. And, you know, every day that looks like medical patients traveling to and from healthcare, but in this case, it's been healthcare relief personnel, it's been PPE and supplies where needed, and sometimes it's been, you know, donating commercial tickets, rental cars, et cetera, to passengers who still need to travel to treatment. And as most of the focus on our country and our world is on the coronavirus pandemic, and rightly so, there's a lot of collateral damage happening in the healthcare community and elsewhere. And we want to be positioned to serve that too. And so we have been planning to resume our flights. We've been working closely with the Air Care Alliance and the Air Charity Network. And we've been really fortunate to have a great team here at Angel Flight. Everyone from infectious disease experts to COVID survivors, and our tremendous board, wing leaders, and safety team helping us plan for this. And we're going to be talking about a lot of that tonight. You likely got sent the documents in your email prior to the event, and there'll be some links in the chat to access some of those documents. And then after this, we will also follow up not only with this webinar, but some of those documents and any unanswered questions we will follow up with as well. So in terms of just some housekeeping stuff for the webinar, so at the bottom bar of your screen, you'll see some buttons for Q&A and chat. Many of you submitted questions ahead of time, so thank you for those, and Dr. Handsfield and Rich will be answering those here shortly. But if you have other questions that pop up, please put them in there. We will try to get to all of them. If we don't get to all of them in the hour that we have together today, we'll follow up, like I said, in email to make sure we get all those questions answered. And then for those of you who are volunteers, either volunteer pilots or drivers, there'll be some more information going out after this. You know, this is a work in progress every day, just like in all of your lives. Things change, new information happens, and we pivot for those needs. And so this will be an ongoing thing for us. And we welcome that feedback, and we've gotten feedback all across the board. So thank you for those of you who have provided feedback. And as we plan and adjust for these things, we'll move forward. Sherry talked about all the current efforts that we're doing. I will talk a little bit about the current state of healthcare and travel and transportation to care. You know, when the board decided to make the temporary suspension of volunteer flown passenger flights, there were a number of factors, but one of those was the lead from our medical teams and healthcare partners. as the coronavirus peaked, many of those healthcare facilities were only treating emergent needs, as many of you've seen in the news and elsewhere. Elective surgeries and cancer treatment, and a lot of that stuff got paused. And so we took the lead from them, and just like we always have done historically for Angel Flight, we continue to take the lead for them. So as you know, our model is matching volunteers with those in need. And we've always vetted our passengers through a healthcare personnel that says they're okay and medically able and ambulatory to fly in a small pressurized aircraft, that their condition wouldn't affect the safety of an aircraft. And now moving forward, we'll be making sure that the risks of COVID aren't affecting their ability to travel. And we're restricting flights to more essential flights. And then similarly, we're fortunate to have a team of volunteer pilots and drivers that have been vetted through the FAA or the DMV in many cases, and are experts in doing risk assessment and mitigation in terms of safety. And so this adds another layer of that safety. And our role, we feel, is to keep everyone as well informed of those risks as possible and let people volunteer on their own volition. And so with that said, as we move forward and resume flights, we would discourage anyone who is at all uncomfortable with volunteering during this time. For those that may have pre-existing conditions or are in a high-risk category, as defined by the CDC, we would encourage you to refrain from volunteering at this time. But for those that do want to volunteer, what it looks like moving forward is we're doubling down on our existing efforts. So on the passenger side, there'll be further screening. Obviously, nothing symptomatic. Anyone that has been in high risk or been in contact with COVID, no travel. Any kind of compassion flights that we've done before that aren't medically related, we're pausing those for now. So the only flights we'll be flying are those that healthcare professionals have deemed as essential for the patient. And the other thing that the healthcare facilities are doing a great job of that we can piggyback on is they're already screening their passengers ahead of time before recommending travel to healthcare treatment, and then doing it again there at the facility. So we will be verifying that through their medical facility, and we're updating our medical releases, et cetera. And then the same thing on our waiver and affirmation, making sure everyone is aware of the inherent risks of COVID and the best practices for mitigating those. And you can see on the documents those listed out, and we'll talk through those a little bit with Dr. Handsfield and Rich Pickett today, our safety officer. And so those are going to be our plans moving forward. And again, we want everyone to carefully consider this with their families, with their plane partners, et cetera, because we don't want to take this lightly, and safety of our volunteers and passengers remains our priority. So with that said, I would love to, we've got lots of questions, and I anticipate we'll get even more. So thank you for those. And like I said, we may not get through all of them in the hour we have together today, but we will be answering those offline. So thank you for those. But I would like to introduce Dr. Handsfield. As I mentioned earlier, we are so blessed as an organization to have a command pilot based in Seattle, flies a 182, former board member, longtime command pilot, and he's an infectious disease expert. Dr. Handsfield is an infectious disease specialist and public health expert and Professor Emeritus of Medicine, Center for AIDS and STD at the University of Washington. And we also have our Angel Flight West safety officer, command pilot, and recent COVID survivor. Thank you all for your thoughts and prayers, as Rich was in care at Kaiser in San Diego and has been back to health and flying recently. So I just want to say, Dr. Handsfield and Rich, thank you so much for joining us. And Dr. Handsfield, we'll start with you. For those of you unaware, Dr. Handsfield has a document that is at the Air Care Alliance website and is also at the University of Washington website, and we'll drop the link here in the webinar chat. He had created a great white paper for us, and won't ask him to review all of those, but we'll ask him to give us his experience and thoughts on as we resume flights for Angel Flight West. So Dr. Handsfield, thanks again for joining us.
Thank you, Josh, and welcome everybody. This is a distinct pleasure, and I am flattered to have been asked to help out, both for this event and in terms of Angel Flight's consultation with me over the last several weeks. My cough is not COVID. So I got involved because a physician named Dan Masis, who is associated with CalDART, the California arm of the Disaster Aircraft Relief. I forget the exact name of the acronym. And they asked him to write an opinion piece, and then it came to Josh's attention, and Josh asked my opinion, knowing my expertise in infectious disease and public health. And so I looked at that, ended up in a close working relationship with Dan Masis, and together we wrote Dan wrote and I edited, and then we basically posted a thing several weeks ago now that reviewed the epidemiology and what we knew about transmission and potential impacts on volunteer pilot operations at that time. Since that time, the data have evolved, and new information becomes available. The off-the-cuff comment among many epidemiologists and infectious disease experts is that we're drinking from a fire hose. The information is coming out so rapidly it's hard to keep up with it. But the latest version, edited as of about 10 days ago, May 19th, of what I summarized, basically goes over what are the transmission risks. And for that, the main take-home messages are that although there's been some debate, discussion, and even controversy, both in the lay media and to some extent in the medical literature, about what are called aerosols versus droplets. Aerosols, teeny particles that float in the air and can go great distances and hang in the air. Droplets, larger particles out of the respiratory tract that fall out of the air promptly. And what proportion of infections are transmitted by one or the other. Some of the aerosol events, like the choir in Washington State, have been well publicized, but they are rare. And the data do suggest, in terms of what protection equipment seems to be preventing infection in healthcare workers, that most transmissions result from relatively large droplets. And that's behind the basic notion of A, 6-foot distancing, and B, masking. Masking prevents the masked person from being a source of droplets and to some extent aerosols into the environment. So you wear masks, but to protect others, pardon me, and not yourself. But they are believed to be very effective in that because they stop droplets from getting out, and to some extent aerosols as well. The other bit of transmission news that's evolved and is mentioned briefly in the summary paper that I've done, and by the way, Rich Picket, who will be talking to you shortly, then took, as he will discuss, sort of the combined work that's already been done, has formulated that into Angel Flight specific advice about where things might go in the near future. But the other thing to keep in mind is that all contaminated surfaces clearly can be a source of infection. They usually are not. The large majority of transmissions by far occur from individual contact with people through airborne transmission, whether through droplets or aerosols. There's a bit of controversy about how important touching surfaces is, but whatever it is the reason that hand washing, frequent hand washing or hand sanitizer and keeping hands away from the nose and mouth are critically important, because none of us can avoid touching all surfaces. Some of us can't avoid being in sufficiently close contact with infected persons. But if we fail and occasionally don't clean surfaces as well as we might hope, the actual risk of that failure probably is low. And I think this becomes pertinent as to how we manage flights with passengers, whether in either volunteer and pilot operations like Angel Flight or other passenger operations. So with those sort of background comments about what the science tells us, a number of common sense procedures that will reduce the risk of transmission of the virus in small general aviation aircraft are pretty much common sense. Most are common sense without data behind them. but I think you'll find most of them reasonable. And I won't go through the entire bulleted list at the moment, but they include some of the obvious stuff like excluding people who are obviously ill, known contacts to known cases, people with certain symptoms, perhaps temperature screening. If you have to be in physical contact, wear gloves or wash soon afterwards, or use hand sanitizer. Perhaps maximizing the air circulation within an aircraft. We know that transmission risk outdoors is low. There's a lot of debate now about what outdoor activities are or are not safe. But the bottom line is that there are few documented virus transmissions when the only exposure was out of doors. And that sort of implies that air circulation is an issue. On the other hand, time of exposure also is an issue. So the baseline risk of aerosol transmission from virus particles floating in the air probably is low. That risk rises with time of exposure. And in a typical passenger flight, you're going to be in a closed environment with one another for an hour to 3 or 4 hours. Maximizing air circulation in the cabin probably helps. But I think it is important for all of you to realize, and this will be my last comment before I turn it back to Josh and Rich, is that 100% protection cannot, with the current knowledge of the virus and the epidemic and the science, 100% protection against transmission during a general aviation flight cannot be provided or guaranteed. You can reduce the risk, and I think you can reduce the risk to sufficiently low levels that the balance between the essential nature of some Angel flight missions creates a decision that is in favor of going ahead with the mission, even if risk can't be quite zero. But that's precisely the dilemma that the board has been wrestling with, and that Josh is working toward operationalizing for you all.
Thank you, Dr. Handsfield, and a great transition. I'll say another personal thank you to Dr. Handsfield. As soon as we heard about COVID way back when, now it seems, some days it seems like yesterday, other days it feels like a long time ago. He's been very helpful in guiding us through this process and has been very consistent in his support for continuing operations for those that need Angel flight. Around the same time, we had one of our own staff members, Rich Pickett, become infected with COVID, and learned a ton from him and through him. So Rich, thanks again for joining us. Thank you for wearing the official Angel flight uniform there. Would you please share with our guests a little bit about your experience with COVID, and then also some of the work we've been doing in terms of, as Hunter said, knowing there's inherent risks, how to best mitigate those, and what we're recommending for our volunteers.
Yeah, thanks, Josh. I'd be happy to. What had happened with me, just briefly, is that, at least from best contact tracing I can get, is on a cross-country trip that involved public transportation, Uber, airplanes, and then hotels. And most likely I had it. And then I was hospitalized on April 1st in the ER with double pneumonia and a very severe case of COVID. And then with less than, 10 hours, 12 hours from going to the ER, was on the ventilator for 10 days. And so my entire stay there was around 17 days. I pushed really hard to get out. 2 weeks later, I was off quarantine, and then I started flying. So I started flying on May 1st. And then, in fact, today I just got back from Arizona. So I've been flying a lot in aircraft, and I've been with various people. So I've done it with my clients in single engine up through jets and turboprops, PC-12s and so forth, and with passengers. And I've been working really hard to be as safe as I can, even though I've got antibodies and I'm not infectious, and the probability of catching is pretty rare. I just wanted to be a good example and also to make everybody else safe. So I've been flying with masks. I've had my co-pilot fly with masks. My passengers have had masks on for the virtual all the time, except when they were drinking something in the back of the charter plane, and everywhere. So I've taken that responsibility, even at flight safety for training. I've done it at FBOs to make sure I could sort of keep some good distance between myself and line personnel, because as you fly, you'll find out that there's variable compliance with social distancing at airports, at FBOs around the country. So you have to sort of take it upon yourselves to make sure that you're safe and keep other folks safe. And then as part of this, we've been working on, for Angel Flight, of when we do resume flights, how to do it as safe as possible. Hunter, Dr. Handsfield and Dr. Maces and others have done an amazing job with information for us, including the CDC and other sources. And over the last several weeks, we've been putting together documents that hopefully will be a guide to pilots and Earth Angels, because they're part of our team as well, obviously, the flight mission team, to when they feel comfortable to resume a mission with our patients, that they can do it in a safe way as possible. And so a lot of the things people say, like on masks, I've been wearing masks in the cockpit with everything from my Cirrus to the turboprops to the jets, and have had no problems with communication. It's not the most comfortable thing, but I've gotten used to it, just like a headset. And but it keeps you safe, and it's a good way to do it. So that's it for now, Josh. I'm happy to turn it over to you and see where you'd like to go from here in the webinar.
Thanks, Rich. Yeah, we've got a number of questions, and as you saw in the chat, please feel free to type any other questions in the Q&A at the bottom, either for Dr. Handsfield, Rich, or myself. Happy to get to those. Also, we'll just discuss timing a little bit. Like I mentioned earlier, it's work in progress. We will take the feedback from here and from the communication over the weekend back to our board of directors on Monday with the plan for resuming flights, which puts, as most of you know, requests swim about a week downstream for Angel Flight. So it would put us resuming flights the following week for Angel Flight. As you can imagine, as elective surgeries have come back online and so forth, we have been receiving increased requests, and our ops team has been doing a great job serving them and letting them know the current situation and asking for flexibility, and in some cases arranging alternate transportation. So that's the timeline on this. And I'll get to some of the questions right now. Hunter touched on this briefly in terms of air circulation and airplane, but we had a couple of questions, Dr. Handsfield. Does a pressurized aircraft have better or worse environment for airborne contagion than a pressurized aircraft? And given the continuous offboarding of air and pressurized versus the open environment of a non-pressurized, how does that affect the risks of virus transmission in the airplanes?
Well, I am a Cessna 182 pilot. I have no personal experience in pressurized aircraft. Don't fully understand the system. So I'll pass part of that answer over to Rich, who does, in terms of what the quality of air circulation and exchange is. I know that on commercial airliners, in spite of popular perceptions about high risk of viral infections when traveling, in fact, they have a very high rate of turnover in spite of obviously being pressurized. I don't know that. I'll let Rich comment on what the case is for most smaller aircraft. The general sense that in non-pressurized aircraft, it is pretty easy, at least in my airplane, I assume most of yours, to open a lot of the vents. The main issue then being perhaps temperature control in terms of air exchange in the cabin. But limit within passenger comfort, I think it can be achieved. But I'll let Rich comment about pressurized aircraft.
Yeah, the pressurized aircraft have, outside of large business jets or the airlines that have filters, don't have filters in their systems. However, there's a constant flow of air. It's not much different than a non-pressurized aircraft. So for example, in a Citation CJ3, we get about 8 pounds per minute of fuel that come into the cabin. And literally it just comes in through the sidewalls, up through the vents or down below, and then out the outflow valve. Same thing with PC-12 or the Clips or any of the pressurized aircraft. So there's a pretty good flow of air. What I typically do when I have passengers is I just make sure my vents are open in the front, even though you'll always get air through the cockpit because it's not a sealed environment. But I do that to make sure that there's airflow. So pressurized aircraft versus non-pressurized, not much difference. Just pressurized, you have valves to shut it off, and non-pressurized, it just leaks out the airplane.
Thank you both. We've got significant questions, including one here in the Q&A regarding disinfecting aircraft or sanitizing aircraft. Dr. Handsfield and Rich, do you want to touch on that first? We'll start with you, Dr. Handsfield.
Yeah, as I said, contamination of or getting infected by contaminated surfaces appears to be an uncommon event. Probably accounts for some cases. the main protection that you should focus on is, in my opinion, is the hand washing, gloving, perhaps after if you're going to handle cargo that might have been touched by other persons, which all cargo will have been. So hand washing or hand sanitizer when not available, and doing your best to remember to keep your hands away from your face and mouth, which is a difficult thing to do because all humans unconsciously contact their face and mouth all the time anyway. But think about it and try to do it less. That's the main protection against surface. Now, on top of that, it makes sense, I think, following a flight with other passengers to, at a minimum, wipe down with a disinfectant wipe those surfaces that are most commonly contact: seatbelt buckles, door handles, armrests, and others, and headsets. I think headset muffs should probably be changed. If you have a muff on the microphone of your headset, I think that probably should be changed between passengers. Beyond that, it can't hurt to also wipe down the controls, the glare shield, and other surfaces. But I wouldn't be so compulsive about it to take hours to try to do it. I think if you take care of the frequently touched items, you're probably in good shape in terms of protecting yourself, plus the hand washing, hand sanitizer, etc.
Yeah, and just as Hunter said, the way we do it, I'll talk about the 135 operations that I help with. So on the PC-12, for example, or the jet aircraft, after the flights, we'll put on gloves. We actually have goggles if we want to put on, and then we'll go through and wipe down the cabin. We'll use Aerocide typically because that works out well and it's non-corrosive. It doesn't use chlorine and so forth. It's a nice way to do it. And then you just wipe down. And then the cockpit will wipe down some of the areas. You have to be careful in airplanes. As I mentioned to one comment back to Mark Donnelly, you have to be careful about that with controls. You don't want to spray anything directly onto any electrical device. If you do want to wipe down some controls, you can simply put it on a cloth and wipe it. For leather and so forth, you want to be careful, but the Aerocide, things like that work well, or you can just use a soap base, even a conditioner will go through and clean that. And then we just do that, just as he said, in the areas. It's amazing what you touch. And as people get out on the airplane, they may hold on to the side of the door. So you maybe want to wipe that down a little bit, or where they brace themselves or a seat. But that's the process that we do. And I do the same process in my aircraft if I'm carrying other folks.
Just as a simple technique I have used personally, this is not officially recommended from a scientific standpoint, but when I don't have gloves with me, and I'm filling the gas tank of my car, I will just take the hand sanitizer I keep in my pocket all the time, or the car, and I'll put enough on my hands so that they're wet. And I quickly, with my hands, rub down the handle of the gas pump before, and then go ahead and do it. And then I would use sanitizer again afterwards while concentrating on not touching my face. I think analogous sorts of things probably apply in general aviation flying as well.
Great, thank you both. And just a quick follow-up on that, because there were a couple of questions regarding this. Hunter, what is the length of time? Is it safe to consider interior aircraft self-sanitized, or I guess what's the length of the time the virus can survive on surfaces?
Well, early on in the epidemic, CDC did some studies applying the virus to various surfaces in aerosols, that sort of thing, metal, steel, cardboard, and then testing at intervals over the next several days. And some surfaces, like stainless steel and so on, the virus survives longer than others. But for the most part, infectious virus is pretty much gone by 72 hours on pretty much all surfaces. Drying, the coronaviruses as a group happen to be, their chemical structure makes them quite susceptible to neutralization by drying and by detergents. And by detergent in this context, I mean any chemically detergent substance, which includes garden variety soap. So they're highly sensitive to those things. The other thing that's a little bit of a problem in interpreting the data is that the easiest and by far the most common test done is a polymerase chain reaction, a test to detect the RNA, the genetic material of the virus. Well, tests like that are exceedingly sensitive, and they will pick up residual bits of RNA that don't necessarily mean intact virus is present. Or even if the virus is there, it's rare for any infection that any single virus particle by itself is enough to cause infection. Typically, you have to be exposed to thousands of viral particles for an infection to take hold. And so positive testing in the environment by PCR doesn't necessarily mean that livable virus is there. It indicates a potential for it, but not necessarily reality. So that's the scientific background. And the bottom line is that I probably would be pretty confident after a day or two, and certainly after 3 days, that even if the interior of my aircraft had been contaminated by somebody sneezing in there that I didn't know about, that it would cease to be a problem after that period of time.
Great, thank you. And also just for our volunteers, Rich and others at ACA and different places, there's quite a few good resources for disinfecting airplanes out there that Garmin, AOPA, and some others have put out there. And then similarly, we found some, Rich found some for cars, for our Earth Angels to do that as well. And as Mark Donnelly just wrote in here, passengers, Angel Flight and otherwise, in today's day and age, feel reassured that things have been wiped down before and after, and people are looking for that. So the other thing that came up repeatedly here, and Ronald asked specifically. So let's talk a little bit about masks. So on the particular masks, and first of all, I'll start with I want to thank one of our volunteer pilots, Rich Conti, who has made masks available to any Angel Flight pilot or passenger that needs to use them through a company that he works with. And so that'll be part of our communication for those that want it. We'll send those to you for masking. But in terms of masks themselves, Dr. Handsfield, there's several questions about durability of masks. One, so like Ronald's question is an old N95 mask left over from last year's wildfires better in terms of protection than a new cloth or surgical masks? And Laurel asks the same thing about mask. What are best practices for mask handling and durability? Can you speak a little bit to the different style of masks and how often you should be wearing them, et cetera?
Well, the tight-fitting filtration masks, such as N95, protect the wearer from being infected because they filter out 99+% of all particulate matter of a size that could carry virus. If the seal is good. Now, proper sealing, people with facial hair like me can't really use them effectively, and so on, is critical. But how important they are to protect individuals really isn't all that clear. In the University of Washington healthcare system, my colleagues who are taking care of COVID patients wear surgical type masks plus plastic face shields plus gowns and gloves as their PPE, but not N95 masks or other devices to prevent aerosol exposure. They protect themselves against droplet exposure. And the infection rate, the proportion of healthcare providers acquiring COVID in caring for patients in the university system is under study by some of my colleagues, not yet published, but so far it shows no higher rate of infection in those people than in other University of Washington medical employees who do not see patients directly, suggesting that the background rate, even those providing care, is more from the community rather than their work. And they're taking only droplet precautions. They're not using N95 masks. So if you have, I would want, even in spite of my beard, or maybe I'd have to shave, if I had a known infected patient in my immediate environment, I would want an N95 mask. For the average passenger who you screened out and therefore is unlikely to have active infection, I don't think it's necessary to go through that trouble. It would be effective in helping you if you do want to add that additional level of protection for yourself. Surgical type masks protect protect people in the environment of the wearer. So if someone wearing a mask has COVID and is coughing, sneezing, breathing, or just talking loudly or singing, the droplets and aerosols that would be expelled are markedly limited. There are no data except common sense assumptions about whether an older mask that's been wet and dampened and reworn several times loses effectiveness. But my understanding of what I do know about N95 masks is they probably retain their filtration capacity, and that for surgical masks, just aesthetically, unless you just don't have enough around, just aesthetically, after I've used it for a few hours and it becomes moist from my nasal secretions, my talking and breathing, I want to change it anyway. I wouldn't worry. I don't think those kinds of masks currently are critically short in supply. My experience is they tend to be pretty widely available. But I think mostly I'd rely on that rather than N95s.
Thank you, Dr. Handsfield. Yehoram, I'll take this one a little bit, asking what can be done to screen passengers for Angel Flight West trips. So the increased screening that we are doing is, and first of all, as I mentioned earlier, our healthcare partners are doing this pretty extensively already. They screen passengers before anyone comes to a treatment. You know, UCLA, for example, has a whole list of things that they ask the patient and measure before they bring them into the facility, and then do the same through there. For us, we are getting updated medical releases for all of our patients, including considerations for COVID. We have updated our waiver of liability to include the acknowledgement of risk there, both for liability to protect the pilot and Angel Flight West. We're excluding persons with symptoms, so no symptomatic flying. We're encouraging passengers and volunteers to screen temperature before flying, because sometimes the temperature can appear before the other symptoms. Anyone with known exposure to COVID within the preceding 2 weeks, or those who've traveled recently to geographic areas with high impact or working on front lines, that kind of thing, we're excluding. And we're excluding others potentially at higher risk as defined by the CDC risk high, the CDC high risks, and that's in consultation with the medical provider. The other things we are encouraging is limiting the number of passengers and companions. We are encouraging the passengers to not sit in the front seat, to distance as much as possible in the flights. And then obviously face coverings that we mentioned already. So those are the things that we're preparing the passengers for, as well as the pilots. And that'll be part of the screening process that our coordinators go through as we onboard and resume flights. All right.
Rich, there were, Josh, there were a number of questions in that had been submitted before. Now there's nothing open in the Q&A.
Yeah, that's what I'm looking at. We've covered a lot of these, but one important one, both Rich and Hunter can talk to this, regarding other people in the plane, specifically a mission assistant or someone flying along with. We are encouraging to fly solo when possible, but when someone is looking to fly alongside of one, what's the criteria for those that don't live in your household, et cetera? Rich, I know you've been flying with co-pilots and mentioned that briefly, but can both of you speak to that in terms of best practices inside the cockpit?
Yeah, what I do when people fly with me, whether it's my first officer or if I have a student, is I have them wear a mask as well. It's a good way, even though I'm not too worried about myself in terms of the virus, I also think it's a good way to make sure that anything I have could affect them. And so we do that in the cockpit. And you get used to it. It's not a big problem. It gets a little bit warm in there, but as I mentioned before, it works fine with the microphone. I haven't had ATC or even my crew ever say that they couldn't understand me. So that's what I do. And in the cockpit, as we're done, if it's on the charter flight in particular, then we'll wipe down the plane and be careful about those surfaces in there. So nothing really special other than just to be real careful. Make sure you, like Hunter said, I carry hand sanitizer in my pocket now, and I'll wipe down my hands more frequently than I ever did before, just because you have a tendency to touch your face or you're moving your mic or things like that. But nothing special other than that. With the passengers, have them wear masks in the cabin of the aircraft.
Yeah, to me, it makes sense. I haven't flown with many passengers other than family member who are part of my local in-house limits for worrying about prevention anyway. My wife and I are quite careful. We're out, we're not going out, we're having groceries delivered instead of going to stores and that sort of thing. And I haven't had any other passengers in the airplane. I would feel comfortable with the screening that we have discussed, screening out people with symptoms, particularly high risk based on geography or known exposure. I'd be a little more nervous about kids, just because small kids are by definition less able to remember to follow recommendations. We're more likely to loosen the mask, talk around it, or cough, or so on. I would be inclined to put passengers who I don't know and who I can't guarantee what their level of safety is in the community in the back seat rather than next to me in the front. But with all those precautions, I really wouldn't hesitate to do the most of the kinds of travel that my Angel Flight missions over the years have required, as long as I had screened out those folks. I think the risk for any single flight probably is low enough that even though I'm in the age group that puts me at higher risk, I would still be comfortable doing it. If I were 40 years old instead of in my mid-70s, I would be that much more comfortable. And those of you who are younger might have different standards than those of you who are of a more mature demeanor.
Thanks, Hunter. And we got a question from Lauren Scott, and we got this question offline quite a bit too, regarding testing. So I received a number of things of folks not comfortable flying unless people are testing. Can we talk a little bit about the conversations we've had, Rich and Dr. Handsfield, regarding testing and free testing that's available in most areas, as Lauren's pointing out, and then the availability and ability to do rapid testing and that sort of thing in the Angel Flight environment?
So testing has been very much in the news, and unless you've been living as a hermit, you will have heard a lot of the discussions. So there are two kinds of tests. There's testing for the virus itself, that typically requires a nasal swab, or it could be, depending on the technique, an oral swab or a gargle or that sort of thing. No single PCR test from any anatomic site picks up 100% of infections. So in hospitalized patients, in whom, because they're hospitalized, you can test multiple anatomic sites. If you do a deep nasopharyngeal swab that goes all the way to the back of the nose, which is almost impossible for someone to do on themselves, or an anterior swab in the nose, or a throat swab, or a gargle, plus sputum if you've done an intubation and have secretions from down in the lungs, plus testing feces, and so on. No one test picks up 100% of infections. So we're probably not going to see, if even in the distant future, we're probably not going to see any tests that can be done in real time, collected by patients themselves, of their nose or throat, that are going to provide 100% guarantee. A negative result will reduce the likelihood by a great degree that they're infected, but it won't be absolute proof. So it's a good technique to keep in mind when and if rapid tests for the virus are available in a format that an individual can do outside a healthcare setting, so that people can be tested before they board your aircraft. That may come, but it's probably months away from being generally available, and even then won't be 100% protected. So the other kind of test is antibody testing. You're looking for the body's immune response to the virus, and there's been stuff in the news about how good the various antibody tests are in documenting that somebody had previous infection or not, false positive rate, false negative rate, and all of that. They're not perfect, but they're getting better in general. And when more widely available, perhaps also with rapid testing, probably, don't know 100%, but probably people like Rich and others who've been infected will show antibody. And if antibody is present, they are probably exceedingly unlikely to be actively infected, and a source infection at that time, and probably immune to a new infection. I say probably because there's some controversy about how certain the antibody tests are in making that determination. I think looking, when we look months into the future, but not weeks, and maybe a year in the future, I think that testing for antibody and or the virus in some combination will make sense and will begin to be feasible. I would not count on that as a strategy to help judge risk or make choices about passengers in the next several weeks or a few months anyway. Could happen. When it does happen, might be geographically, I might have better resources in Seattle than somebody does in rural Wyoming, to pick an example. But I think I wouldn't count on tests as a short-term strategy.
In my particular case, and I agree with Hunter, I was calculating, and I'm sending out to the wing leaders and the safety officers, if we try to do tests on everybody, if we have, let's say 5,000 missions a year, you'd have to test everybody before each mission, each leg of the mission actually. And in my particular case, I was asymptomatic for several days, and we put that in some of the information sheets that we're distributing. So you just have to be careful on that. And I noticed that Mark mentioned that he found a FDA approved no-touch digital forehead thermometer, which is a great, because one of the first things I had was a fever, and then a very deep sort of, it ended up becoming pneumonia, double pneumonia, but the fever came on. And so I also recommend to people, one of the things that really clinched it for me is I did my test with Quest. The test was not back 4 days later. I was getting worse and worse. My temperature went from 97 to 103, right? Back and forth. But was my sister, who's an MD PhD, gave me her pulse oximeter, which I couldn't find mine. And that was a key for me when it really got worse. So at least from a side note, if you do feel bad, pulse oximeters is a great way to also give you an idea of how well you're doing. And of course, it's good to have it in flight anyway, just from a flight perspective if you're flying at high altitudes. But at home is when I use that. There was another question, and I was going to write back this about the eye protection, and Hunter may chime in because he's obviously got the medical expertise that I don't. I wear eye protection. Sometimes I wear my contacts, or I wear sunglasses, or now I have my eyes on here. Partially because it helps protect your eyes, but also it helps prevent you from actively touching your eyes, make you a little bit more aware of that, because there may be other ways of transmission from your hands into your eyes and so forth.
Yeah, I agree with that. I think that again, it can't hurt to have eye protection, but if you have, I look at the entire risk perspective from an epidemiologist's standpoint. If I'm in a community with, say, a modest average likelihood of infection, which is what community statistics are, they're not sky high like they have been in New York. They're not in the cellar like they have been in Montana and Hawaii, but they're somewhere in between. In those settings, if someone has no symptoms, has no known exposure, then the likelihood they're infected is going to be under 1%, under one chance in 100. If I add to that the fact that they are masked and that I'm taking the other precautions we've talked about, and I'm being careful not to touch surfaces and to wash my hands frequently and use hand sanitizer, I think the risk for that particular flight that I might get infected drops to 1 in thousands as an odds. We all have different tolerances for risk, however. Some of us are more risk tolerant than others, and your own age and underlying health issues are part of the picture as well. I put the whole business about deciding whether to fly with passengers, whether it's a volunteer pilot operation like Angel Flight or any other, in the category of pilot and command authority and responsibility. In addition to all the standard stuff, like weather, aircraft maintenance, terrain, and the other things that make us choose between a go or no-go flying decision, we now have to add coronavirus prevention. It's within PIC responsibility. But that's why I say you can't reduce the risk to zero. I think adding eye covering, such as goggles or mask, probably adds an additional increment, but it's an additional increment on top of a pretty safe set of protections, even without it. So personal preference, by all means, feel free to do it, but it's not something I would go out and buy goggles for that purpose to have in my airplane.
Yeah, Hunter, and I was thinking about, as you're talking about the masks, to me, we've all seen, remember there was emergency descent in one of the airlines, and they show the passengers with a mask over their mouth instead of over their nose and their mouth. It's not going to help them get oxygen. The same way, probably we've all seen folks wearing masks with just them over their mouth and not over their nose and their mouth, or ill-fitting ones. So my recommendation, Hunter may want to chime in, is if passengers do have masks, including people in your cockpit, make sure that it fits well and it's over their nose and their mouth. Otherwise, you're going to get some limited effect.
Right.
Good note. And Hunter, you kind of touched on this, but we've got a couple questions specifically from Chuck and Paul. When someone is assessing their own level of risk and doesn't have any symptoms except for perhaps being over the age of 65, what would you say to those folks that are asking that question?
In effect, it's already been implied by everything we've said so far. We have different levels of risk tolerance. I'll be honest with you, at a personal level, the notion of being intubated and not communicating for 10 days, as Rich was, it just scares the pulp out of me. It's just one of those things. I've been involved in carrying patients in that situation much of my life, and I always feel extraordinary empathy and personal anxiety, not wanting to be in that position myself. So my own threshold. On the other hand, philosophically, in terms of most of the way I've run my life, I'm a little bit of a risk taker. I'm not, I'd ski the bumps when I was skiing hard and take the risks there. My own tolerances, my own minimums for IFR conditions are not as stringent as some people's are, based on our own philosophy generally. So for me, I would have to decide for each individual potential Angel Flight mission. I have to know more about the individual, what their level of need was, and how much risk I wanted to take. For the most part, even though I'm in my mid-70s, I would be happy to fly most of the kinds of patients that I have flown in the past for Angel Flight. But I'm not you, and you're not me, and each needs to make their own decision. That's why I said before, I think your age and your medical conditions is part of the mix of information to put in, but I wouldn't make an absolute solid recommendation one way or the other.
Yeah, and Charles asked that question if we're excluding any of those groups, and we're not. As Hunter said, we are leaving the risk assessment up to you and encouraging any of those that are at all uncomfortable not to volunteer. Rich, you and I have talked about this a lot. Do you want to add anything to that in terms of each volunteer's personal decision?
Yes. The document that I think Josh and Mary sent around, and we'll send it out to everybody shortly with a couple of edits and so forth, try to give you a very, very objective look at the situation for your own risk level. And in my particular case, I'm 66, so matches the age somebody else mentioned there. And Jane is older. Jane caught it from me. Thankfully, her symptoms were not nearly as intense as mine. So it was about a week of discomfort and headache and et cetera we talked about. And so each group is a little bit different. I really think people need to be very comfortable with the decision. When I first went back to flying, I was going like, okay, now what am I going to do? Am I going to fly? Am I going to isolate myself? I had a lot of clients who wanted me to fly with them. And I said, okay, I'm just going to be very, very careful about it. And you also have to realize that whatever decision you make is not just affects you, it affects the other people that you may come in contact with, such as your family and friends later. So you have to make that decision and be very careful of it. When I did my cross-country trip, I had a mask with me, but I didn't wear it very much. It was at the early stage of all this going on. I thought I was separated from everybody. in retrospect, I should have probably wore it on the entire flight instead of a short period of time. So, you know, that's at least my personal perspective. I've flown, today's the 29th of May, since May 1st. Today I just flew back. I think this was my 28th or 29th leg this month, flying all different aircraft. And then I'll be flying again tomorrow. So I feel comfortable, but I realize I have to be more cognizant of the environment and the people in the aircraft. And then just have to, as Hunter said, you've got to make your own decisions. We want everybody to be comfortable. And that also includes the Earth Angels, because they have to transport the patients within the vehicles, and of course the passengers themselves.
Thanks, Rich. And as we're coming up on an hour here, Dr. Handsfield and Rich, any final thoughts before we close out?
I think all the points I would want to make have been discussed either directly or indirectly. There's a final question, or a question up there from someone named Ray, who asks about flying out of higher versus low prevalence area. Would flying in and out of San Francisco, Portland, or LA be different than other places? And I think the answer is sure. I think we've said that, and I think Angel Flight's guidance will say something along those lines. The considerations for a go, no go, a balance between the essentiality of the flight, the importance of it for the passengers, the extent to which the pilot wants to altruistically serve those needs, versus all safety aspects under your PIC responsibilities, including coronavirus safety, that the background prevalence in the community where you're meeting your or perhaps delivering your passenger makes sense. It is rational to say, if I'm at Teterboro, the New York area, I'm probably going to be a little more cautious than if I were in Butte, Montana. Montana having, I think, the lowest, or one of the very lowest rates of infection in the country. So that's a rational thing, but it's not something that rigid rules can or should be built around.
Thanks, Dr. Hansfield. Rich, any final thoughts?
No, I just think if anybody has any flight questions, of course, you can always reach out to me, rich.pickett at angelflightwest.org. As I mentioned, it's just, you know, personal decision. People have to be comfortable. If you don't feel comfortable, there are other ways that you can help. I mean, Angel Flight has been doing an amazing job with PPE deliveries to various locations, as Mary talked about earlier, and Sherry and Ivan, the whole gang have been at Angel Flight West, have been coordinating some amazing flights. So you can always help them that way. And you just want to make sure that this is the right decision for you. You know, personally, when there's missions that become available with patients, I'll do them, because I realize that there's some folks that really need the transportation. The physicians that are requesting them deem these as being essential, and that the risk for the patients is lower in an aircraft than it may be in a long-term other type of transportation. But again, as we've all said, everybody's got to sort of make their own decision, what they're comfortable. You don't want to later on worry about that, whether you made the correct decision.
Well,
I'd like to add my offer to Rich's. My email address is very easy, and individual communications are entirely welcome. I jumped in early in the University of Washington system, so I have a very simple email address. It's my initials, hhh@uw.edu.
Well, thank you.
University of Washington won a domain name legal fight with University of Wisconsin several years ago about who got to use UW.
Oh, good.
Well, thank you both again, both for today, but also the hours of exhaustive emails and phone calls that you've received from me and the team, and for making yourself available. As they said, and like them, you can reach me, Josh O, at angelflightwest.org, or through the Angel Flight phone number. Welcome feedback, welcome questions. Like I said, next steps for us is we're going to recap this. All the materials that we mentioned are going to be in a knowledge base that anyone can have access to, whether that be, you know, best practices for disinfecting, for masking, for the regulatory guidance for state by state, all those types of things we will make available and have resources aircarealliance.org also has really great resources out there for folks and links to get more information. So I just want to close, and several of you have been here. I just want to say thanks again for all of our volunteers. We've had many supporters step up and help us through difficult times, both operationally and financially. We are still running our COVID fundraising campaign and just had a new match come in. So there'll be more information on there, but there's a link over in your chat if you'd like to donate there. I'd like to thank our partners at Alaska Airlines for helping get these healthcare heroes to the front lines. As Sherry mentioned, we've arranged over 100 of those flights. So if you know of someone who needs that, please do. Rich mentioned the PPE. You know, those are, we've been pursuing hundreds of those opportunities, trying to find the right nonprofits to partner with. Someone had asked about if there's anything in Northern Cal. We are still pursuing all of those options. The PPE needs are not going to stop. This is going to be a continued need. And for those that are doing it low and no cost, that don't have other transportation options, we're happy to partner with them, like we have been doing at the Navajo Nation and rural hospitals in Colorado, in other areas. So if you know those, please send them our way. Even if you don't have a personal contact, but you just have heard of something, you know, send those along to myself or Ivan, and we will follow up on those. And again, thank you each for considering volunteering with Angel Flight, and we respect those decisions. We will ask those who are planning, just so we can get a sense of supply for the incoming demand. Neville's question was answered offline, but I'll close with that, is what we're expecting to see. You know, our patients are wary about traveling too. They are, many of them, immune compromised themselves, and, you know, are not only terrified with their own illness, but then, you know, having a potential illness on top of that would, you know, wipe out the progress that they may have had with their treatment. So right now, those requests are coming in slowly from our healthcare partners and the patients we talk with. Many have been delaying their treatment. How they decide to travel there, or if they decide to travel there, remains to be seen. We do anticipate, you know, as the curve continues to flatten, more and more people are going to resume needing treatment and traveling there. So we do anticipate that. But right now, we want to be for those that need us most critically. And thank you for weighing that considerately. And thank you all too. I saw several folks give feedback on other things and other considerations, everything from temperature screening to masking, et cetera. Thank you for those. Keep those coming. We can add those to the knowledge base too. And with that, I will close and say thank you again. There's more links on site. We'll follow up with this, both with a recording that you can forward this to family and friends, and we'll reach out to the rest of our volunteers with this material and this recording as well. And keep those questions coming for Rich, Dr. Handsfield, and myself. And thank you again. We wish you have a very happy weekend, and we look forward to climbing above this together with you. So thanks so much.